who is Joyce REIMER. Joyce, are you here?
Yes, I'm here. Can you hear me?
Yes. Can you turn on your camera? Perfect. We can see you. Can you share the screen the screen now? All right. We can see you.
I'm going to try to put this in full screen and let me know if you can still see it.
Yes, it's starting to appear.
Can you see it now?
It's dark so far.
Okay, I think I will just have to present like this then. I've had issues like this before. So
maybe
we'll go back to this mode.
Okay, for us it's perfectly visible. Okay. So we can go on like this. So I'm glad to introduce you Joyce REIMER. She's from the University of, here I'm not going to pronounce it very well, Saskatchewan, Canada. And she is going to present a study, a numerical study of long QT syndrome. Please, the stage is yours.
Hey, thank you very much for the introduction. Yes, so my name is Joyce REIMER. I'm a master's student of biomedical engineering at the University of Saskatchewan. I'm supervised by Dr. Raymond Spiteri, and the rest of our team is listed here. Sebastian Dominguez was presenting yesterday on some of our other work, tuning parameters of several cardiac models. So hopefully you were able to make it to that. But I'm going to present a slightly different angle of our research, which is a numerical simulation of long QT syndrome, symptoms, triggers, and treatments. So here's an outline of what I'll cover. I'll give you some motivation and background as to why we are studying long QT syndrome. And then I'll present our simulations of long QT syndrome 2, followed by long QT syndrome 1. And then I'll finish with some conclusions. So I'm sure you're familiar by now with computational cardiac models, but there are a few different types. So you have electrophysiological, biomechanical, and hemodynamic. We're mainly focused on electrophysiological models for now. There are some uses of cardiac models, including research applications, planning surgical procedures, as well as trying to get them to be used in personalized medicine approaches. However, they're primarily still used in research settings, and this is because there are some challenges associated with bringing them into the clinic. Some of these challenges are that the simulations may lack detail. Also, there are heavy computational demands, and there's probably going to be long computation times, though that's slowly getting better. And then the parameterization process to actually model specific diseases can be kind of a challenging process because the data collection would need to be so intensive. And also there are some discrepancies between the different models, which means it's difficult to standardize representing a range of disease conditions. So with these challenges in mind, the research question that we ask is how can we make cardiac simulations more accurate and customizable in order to effectively aid electrophysiological research and increase cardiac models' feasibility in clinical settings. So this is sort of shaping the research that I'm going to present to you. And we're hoping with this work, we can sort of begin to form a path or a process for representing specific clinically relevant conditions. So to give you an overview of long QT syndrome in general, it's a channelopathy. So this means it's a disease of the ion channels on the membranes of cardiac cells. The name comes from the prolonged QT wave on an ECG, which comes from the delay in ventricular repolarization. The symptoms are quite severe. So you have a torsade de pointe arrhythmia, syncope, or sudden cardiac arrest. And the syndrome may be congenital or acquired. We're mainly focused on the congenital versions because this has genetic expression, which lends itself well to personalized medicine. So to start off with long QT2, long QT2 is caused by several different mutations in the KCNH2 gene. And this gene encodes a subunit of the channel that conducts the rapidly activating potassium current, IKR. So every long QT syndrome has some sort of trigger associated with it that can bring about an arrhythmia. So for long QT2, the classic trigger is a sudden auditory stimulus, such as an alarm clock or something that startles the individual. And then there's a sympathetic tone surge that happens that may potentially lead to an arrhythmia. So the cell model that we used to simulate this condition is the Grandi et al. 2010 cell model obtained from the CellML repository. This is a system of 38 differential equations solved with MATLAB's ODE15S solver. And for these simulations, we just perform them on a single cell. We wanted to also represent a realistic startle response as the trigger. So to do this, we looked at data that was acquired from Ramirez et al. In 2005. So you can see the plot on the right are the heart rate changes of individuals who were undergoing a startle response in response to sudden auditory stimuli. So we use this changing heart rate to apply a piecewise function to the pacing of the cells in our simulation, so that it was changing frequencies over time rather than just having like a constant frequency, as you normally would probably have in a cardiac simulation. And then for the LQT2 phenotype, we acquired the data from Itzhaki et al., who characterized an A614V missense mutation in the KCNH2 gene, which resulted in LQT2. So we used this data that was presented in their paper to parameterize the Grandi et al. Cell model. So these are our simulations. First, we needed to make sure we had an accurate LQT2 phenotype. So to do that, we adjusted the conductance parameters of IKR until we had a current density that matched that of experimental data, which was from Itzhaki et al., which was between 57 and 72% reduction. So we got it to about 65%, and you see the current density plot right there. And then to further verify the model, we looked at the lengthening of the action potential, since this is characteristic of long QT syndromes. So just at a baseline level, there's just a slight increase in the action potential duration. However, once we applied a sympathetic surge by changing the calcium dynamics of the model, it drastically increased this dashed line out here. It was a 145% increase in the duration of the action potential. And this was within the experimentally reported values from Itzhaki et al. So that assured us that we were fairly accurately simulating the specific mutation. So then on top of the sympathetic parameter changes, the calcium parameter changes, we applied a full startle response with the changing heart rate. And as you can see in the trace at the bottom here, there are quite a few action potentials that are skipped, and there's some erratic activity. And when you zoom in, you can see there's some extraneous peaks in the traces of the LQT2 phenotype. And these are called early after depolarizations, which are thought to be precipitating events at the cellular level for an arrhythmia to occur. So then to round out the story, we wanted to also simulate potential therapy for LQT2. So calcium channel blockers have been studied for their preventative ability in long QT2 syndrome. So we again changed the calcium dynamics in a different way to simulate these calcium channel blockers. And we saw that there was a normalizing effect on the action potential duration. So with the filled in circles, here is just at a baseline level. So it's shortened and it's closer to the control action potential. And then even when we apply a sympathetic surge, we see a much less pathological extension of the action potential. And then it also holds up when we apply that startle response, which is at the bottom here is long QT2 with the calcium channel blockers. So we were able to simulate the symptoms and the triggers and a treatment for long QT2 syndrome. So then to move to long QT1, this is the most common variant of long QT. It's caused by several different mutations in the KCNQ1 gene. And this encodes a subunit of the channel that conducts this lowly activating potassium current IKS this time. So the trigger for long QT1 is also sympathetic tone, but this time it's through exercise rather than through a sudden loud noise. And on the right, you can see a schematic from the paper that we used to parameterize our model, Ma et al. 2015. So they characterized an exon 7 deletion mutation, and that affected the pore region of the channel, which then affected the conductance of the potassium ions. So this time we wanted to simulate 2 cells. So to do that, we used the ME model, or the extracellular membrane intracellular model. And this model was first developed by Agudelo, Toro, and Neef in 2013 to simulate individual neurons. But then later in 2017, it was adapted by Tuvedo et al. To simulate individual cardiac cells. So what's unique about this model is that it actually defines the membrane as its own domain, and it keeps the intracellular and the extracellular space separate. So this is quite a bit more detailed than like the bidomain or the monodomain models. And so we thought that because long QT syndrome exists on the membranes of cells, that this would be a good candidate to use. So the system of equations is presented here. You have some diffusion equations on the extracellular space, omega E, and the intracellular space, omega I. We're interested in solving for V, which is the transmembrane potential. And that depends largely on I-ion, which is the external cell model that we can link to this system of equations, such as the Grandi et al. Model or the Tentuscher and Pamphilov model. This is the term where you would link it. And then W is the potential across the 2 cells, which depends on the current flow across the gap junction. And these are the boundary and flux conditions. So NE is the unit outward normal on omega E, and NI is the unit outward normal pointing out from omega I. So we have 0 flux on the on the external boundary, but there is continuity of flux across the membranes. So to solve this model, we used a first order Godunov operator splitting method with forward Euler for the nonlinear cell model and backward Euler for the linear system. We spatially discretized using the finite element method and implemented it with the FreeFem library. And this time we used the Tentuscher and Pamphilov 2006 cell model. And at the bottom, you can see the domain that we were using. So the 2 inner rectangles are the cardiac cells, and then the extracellular space is this omega E. So we did similar verification simulations as was presented with LQT2, where we looked at the reported values of the current density, and we adjusted the conductance to account for that and get a baseline LQT1 phenotype. And then we also looked at the corresponding extension of the action potential duration and made sure that it was matching with the values that were reported by Ma et al. So once we did that, we then wanted to simulate a trigger again. So we added sympathetic tone or simulated sympathetic tone by adjusting the calcium parameters again in the Tentuscher model. And then we also wanted to simulate it along with exercise. So by doing that, to do that, we increased the pacing to an active heart rate. And you can see the bottom traces here is the disease phenotype. So every other action potential is skipped. And there are some early after depolarizations that you can see right there compared to the control. And then again, we wanted to simulate a therapy. So a common first line is beta blockers. We reduced the calcium conductance by 50%. And again, we saw a normalization of the action potential duration compared with this solid line is the control, and the LQT1 without the beta blockers is this dashed line out here. And even at a higher heart rate, we saw that there were no early after depolarizations, and the beta blockers appeared to be working. So for both long QT2 and long QT1, we were able to simulate symptoms, triggers, and treatments. And this is significant because not all LQT syndromes will respond well to the same medications. And even within a type of long QT syndrome, there are several different mutations that may all have particularities and respond differently to different treatments. So in doing these sorts of simulations, we can start to explore those particularities and perhaps determine what the best treatment is for a patient's specific type of long QT or their specific mutation. So some conclusions: parameterizing cardiac models to emulate disease phenotypes may shed light on pathogenic features. We saw some clinical applications, which is that we can observe a patient's disease under different conditions that may not be possible to accurately reproduce in a classic clinical setting, and also that we can determine best therapy for a patient's specific LQT mutation, which has implications for precision medicine. And then, of course, there are research applications in which we can look at LQT triggers and predict their effects. And the future work of our team, we want to keep looking at this ME model. So we will, excuse me, we'll continue to look at long QT syndromes in different ways through the lens of the ME model. And we also would like to scale it up to more than 2 cells so that we can observe tissue properties rather than just cellular properties. And then we also would like to use it to model complex geometries and to explore ephaptic coupling mechanisms, or the extracellular electric field effects that exist between 2 cells that couple them through more than just their gap junction. So these are some of my references. Thank you for listening, and please feel free to ask me any questions.
Thank you very much. Very clear talk. Very interesting, I will say, study, and the stage is open for questions from the audience. Any question? Well, if not, I have a curiosity, which is related to the EMI model.
Do you want to look at it?
Excuse me?
Do you want me to go back to the slide?
If you like, yes. You applied it to 2 consecutive cells, right?
Yeah.
And
right.
My question is the following. So why 2 and not why a full chain of cells, and then focusing on the ones in the center? And then a question that is still related is the following: how much important is the shape of the cell that you consider in this model? And also you put the cell into a rectangle, which is mimicking the extracellular space, right? So you have an idea of the role of the distance between the cells and the walls of this domain that is representing the extracellular space?
Sure, yeah. So first of all, why 2 cells? That's a good question. We were kind of just getting comfortable with the ME model. So we started with 2 cells because that is kind of the first, like the simplest representation of the model. And we found that it was sufficient to see, to observe the cellular level activity of long QT syndromes. And we were looking at all of the measurements, by the way, on the second cell, not on the first cell. So there was some movement that occurred. But definitely in the future, we would like to extend it to more cells. However, it's going to be obviously very computationally demanding. So we're wanting to make sure that we have some parallelization implemented and some efficient solving methods before we extend it to too many cells. And then you were asking about how the shape of the cells affects it. Yeah, so we looked at if we just had like square cardiac cells versus rectangular cardiac cells. And it does actually make a slight difference in output. I'm trying to remember what it was. I think it was perhaps a longer action potential duration slightly in the rectangular cells. But there is definitely, even with like slight changes in the dimensions, there are differences in output. And I think once we change the shape of the membrane to simulate T tubules, I'm sure there will also be some changes that we see there.
Yeah, okay. this is, I mean, it was just a curiosity, but I think some role can be played, and maybe it can help having, let's say, a more complete assessment of the result to make sure that they are not, the comparison among experimental data and numerical result is not biased by some, let's say, numerical artifact that is introduced by some assumption. Excuse me. So, like, to thank you again for the very nice talk, very